Today on the Cameron Journal podcast, I am joined by Greg Vigdor. He is let me see here, I have it here, a former healthcare executive who's escaped the perils of Mr. Mangione, and and he is now a writer. He writes medical thrillers and talks about healthcare policies. He has released his third book in the Irv Tinsley Health Policy Detective Series. And so we're going to be very excited to talk about this, especially given the fact that we're just now shooting healthcare CEOs in the street in this country. God bless America. So, welcome, Greg, to the Cameron Journal podcast.
Thanks, Cameron. Glad to be with you.
Glad to be with you too. All right. Well, let's dive in to all of this. Why don't you tell us a little bit about yourself and your book series?
Sure, well, you covered a lot of it in your beginning. I really am a recovering healthcare executive who, when I stepped away from my last job, decided I'd do one of my bucket list items. When I was a little kid, I wanted to write the great American novel, so I started playing around with doing that, and I found I had a lot of time because that was around COVID.
Oh
And
my.
so I just sort of wrote a bucket list novel and figured I'd get one copy printed and stick it on a shelf and check it off and find the golf clubs. And sent it to some friends, and they thought it was pretty good. So they encouraged me to get it published. So I explored self-publishing, got a great reception for the book, learned a lot about what it takes to write books and publish books. And now I'm on my third book and actually halfway through my fourth, trying to build a second career as an author. But uniquely, what I'm trying to do is not just write novels, entertaining novels, it's the center of it, but embed them with lessons about real American health policy. That's what I spent 40 plus years of my career doing, trying to reform American healthcare and rebuild a system that really doesn't work all that well. And by the time I stopped working and sort of semi-retirement, I realized I'd put a lot of time into it, proud of a lot of what I had done, but I had to admit the system itself was still just a mess and that we need to continue to figure out a way through this. So that's my dream continues to be that we'll fix American healthcare for the better and give Americans the healthcare system that they need and deserve.
Yes. Well, what inspired you to write this book? And tell us a little bit about one. Like it says a detective series. So what is the basic idea of how these books come together? Give us a taste.
Okay, so it starts with the core of a medical thriller detective framework, which is something bad happens, usually something pretty gory. My
Yeah.
latest one, it's a woman waking up from a coma from a long COVID and finds herself in a strange medical care facility where they're doing things that she's never seen before, and she knows something about healthcare. So where is she? What are they doing? Well, that starts to run into my villains. You've got to have great villains in medical thrillers. And we find that world domination is not too far away from the reasons why she's sitting in this strange medical care facility, wondering why people are dying around her. And we have our characters. Our protagonist in my series is a gentleman by the name of Irv Tinsley, and he and his friends are extraordinarily talented detectives who are able to unravel these mysteries and find the ways through what seem to be horrific problems that no one should ever experience in healthcare until I discovered that actually it did happen in real life. Um, and so again, this is really the entertaining page-turning feature of these books that really is the heart of them. But what my thought was after spending 40 years of talking to people seriously about health policy was that, well, maybe we can reach a lot of people with the entertainment value and sort of
Yeah.
incorporate into that the very real things we can do to make our system better. So that's sort of the description of the book without getting into the gory details of them.
Yeah, yeah. No, no, that's good. That's fascinating. I mean, what do you think the biggest problem in American healthcare policy is?
Well, there's a number. We really want to strip it down to the core of the systemic reasons why it doesn't work the way it should. It's really the fragmentation around the system. It's not a system in a true sense. The pieces don't connect. It's why people have such a frustrating experience with the system. Just about everybody. One of my favorite stories is always I spent a lot of time in the hospital world with hospital CEOs, and it always amazed me when I would hear their experiences with their very own hospitals when suddenly they got sick or their spouse got sick or somebody knew they got sick and they had to navigate their own systems that they had more power than anybody to somehow control. And they found they couldn't control it. And that's sort of
Mm.
the nature of healthcare beyond just hospitals. The entire system just does not connect into an organized fabric. Instead, it's just a piece here and a piece there, frequently working at odds against each other, and with the American consumer and patient stuck in the middle. That to me is the core problem of it. And so when you start talking about solutions, you have to start talking about ways to bring it together, ways to bring more people and patients into this system, ways to bring providers into it more closely, and ways to somehow deal with the ones who are really controlling the system more than anyone, the people who pay the bills, the insurers and the government. They need to find a new role that's a productive one, not the one which is right now owning the fragmentation.
Yeah, I mean, I think one of the central problems, at least on the consumer side, um, is very simple, but it's one of those problems that's it seems very simple, but it's of course very complicated. People have a problem, they go to the doctor says, you have X, you should do this operation, have this test, take this medication, whatever have you. And the person's like, great, sounds fine. And that's kind of when the problems begin is, oh, then the immediate question is, will my insurance cover that? For my older listeners, will Medicare cover that? I've been a working artist my whole life, so sometimes for me it's been, will Medicaid pay for that? Sort of thing. And uh just trying to figure out that. And so I think for the average person, they just want they want to be able to um they want to be able to uh get the care that their doctor has ordered, and they want it to either be incredibly affordable for them or covered by the insurance that they pay for or their employer pays for or whatever have you. That seems incredibly simple, but it's somehow not. And I think for most people, that's how they want it to work is, okay, let's do this. I either need to pay for that in cash, which I've done, or that needs to be covered by the health insurance that I pay for sort of thing with, whatever needs to happen. But it seems like the insurance companies and the government make that much more complicated than necessary. Why do you think that is? And how do we get consumers to get the experience that they're looking for, which is just getting the healthcare they need?
So I think you're right on target with that. To one extent, it's sort of just one of the symptoms of the system that's not a system, the fragmentation. But in many cases, it's actually quite intentional. It is
Hmm.
the notion that if you set up these roadblocks, that you're going to be less likely to get that procedure. This is a classic insurer strategy. Just makes it more confusing and less likely you're going to get that intervention, which will save the health plan money. Are they intentionally trying to make sure that people that need healthcare don't get it? No, probably not necessarily. It's probably not even stated in the organizational goals, but the notion of somehow reducing utilization is a goal of that plan. And so
Right.
if this is the way it gets produced, at one level, the corporate reports will say we're doing a good job, we're doing what we wanted to.
Right.
It's not only, it's even more complicated than what you're describing because on both ends, one is it's not a question of whether you're going to be covered necessarily. Frequently, people can figure that out. The question is, how well is it going to be covered?
Mm.
Is it going to be a $500 copay with then $7,000 on the back end, or is it all
Right.
covered? But it's also complicated on the front end. You're presuming that you have enough time with this physician. Most office visits for physicians are on average like 7 minute limit. Do
Yeah.
you have enough time to be sure that you've got an accurate diagnosis and you really understand that is your option for what you need? And how will you get that before you even go to that extreme of that answer to that problem? Do you even have the right problem? So
Yeah.
it's up and down the line. It's complicated and again, intentionally so at times, but it's part of the just the way it just routinely works every day. I've been really healthy most of my life. Now that I'm 70, I'm actually using healthcare more than I ever have before. And as an expert who's lived the system for almost 50 years, knowing it in the ins and outs, I'm amazed by how confused I am when I go see a provider.
No, I mean, this is the classic, the classic problem and the classic trouble. So I've been kind of a bit of a healthcare user my whole life. I've had severe asthma since I was 7 years old. And insurance companies hate covering asthma inhalers. They've never gone down in price. Like I remember when they first came on the market, they were new when I was a little kid because they'd just been
Hmm.
out maybe 5, 10 years when I got diagnosed. Um, and to this day, and I've been having this fight for 25 years at this point, like to the even longer now, almost 30 years. To this day, I have one inhaler now. Every single refill. It is a fight. Always a fight. It's become so
Yes.
notorious. Even Amazon Pharmacy is like, oh no, we do this all day, every day. They never want to cover these things, sort of thing. This is why people are such fans of Mr. Mangione. Like this, and
Right.
I mean, if you have diabetes, it's worse. If you have cancer, it's worse. People have been denied coverage for operations as they're literally walking into the room. Or there's the anesthesiologist that was out of network that is not covered for the surgery that you had to have, sort of thing. This is a disaster. Where do we start to fix this mess?
Yeah. So my prescription for answers to this is really to think about redesigning the system with one thing as its imperative, which is the patient and people are at the center of the system. This is what we're trying to, who we're trying to heal, who we're trying to care for, who we're trying to build health for. And if we started from that orientation, we'd be well on our way to solutions to these. Instead of we get these things because it's organized around the payers and the government and
Right.
the providers, which is getting at least closer to a way where the system might work, but still not sufficient. It's much more about how do we put you and your problem with your inhaler at the center and ask your question, how do we make sure you get your inhaler because that's what's going to help your health? And it
Right.
seems
Yeah.
like a simple thing, but it's not the way it works. It just isn't. And when you start to
No.
suggest practical ways to try to get there, I've spent a career trying to do this. It was part of what my jobs were. I'd start getting that. Well, we can't do that because, well, the becauses don't make any sense. What makes sense is trying to get there and trying to figure out how we can build the political will that will be necessary to kind of crash through this calcified system to where we can start thinking that way and doing it. I try to write about this as
Yeah.
part of the solutions in my novels to the practical problems I try to present within them.
No, no, that's art is an excellent way to discuss subjects like these that are so very dense. I mean, I mean, in my mind, I think the solution is right in front of us, and it's some sort of universal healthcare national plan, Medicare for all sort of thing. There's multiple models to pick from. You have the National Health Service in Britain. The Danes have a national health insurance, as they also do in France. Like, there's other countries who figured this out, and we're just all sitting around here in America being like, oh my goodness, what do we do? And I'm kind of like, well, I think the first step is let's completely stop listening to any lobbyist from a health insurance company. Then once we stop listening to those guys, then maybe we can have a discussion about how to, fix this and even have a public and a private system. Britain has this. If you're
Right.
wealthy in Britain, you can pay for private insurance and become a member of a private hospital, all this type of thing, and the National Health Service keeps on trucking. So don't think just because you're rich and can pay for your own healthcare that we're going to stick you in the public hospital because my mom herself will revolt. No, no. Like, no, no, don't worry. We can like have both. I don't understand what is stopping us from taking a few flights to some other countries, taking some notes, and then cruising back to Washington and writing some legislation. What do you think is the barrier there?
Yeah, so I've actually done what you suggest. I've been to other countries and looked at their healthcare systems.
Oh, see,
I'd
everyone, we
say,
have the man who knows. We've got the right
well,
person on the show today.
I know some of them, and you can get there with what you're describing, but there's other
Yeah.
ways to design a system. So Germany, Australia, they have systems where they're much more built around private insurance, which is sort of a precept of ours.
Mm,
But you have to think about it as a system. One of the great failings of the U.S. health system compared to almost any other one was we were one of the few nations on earth that didn't really include everybody. And just
right.
from a system design point of view, in healthcare, if you don't pretty much include almost everybody from the beginning, you're lost because you're spending so much time trying to deal with those that are outside of it, those that are left out of the system and show up at the emergency room with multiple organ failures. And you have to figure out how to deal with that person morally and actually by law. And then
Right.
because of the consequences of that and how much costly it is and how much it disrupts every other aspect of that care, you're left chasing your tail, trying to make the rest of the pieces come together. So we could start for your precept. I would say that it's hard in this country because of the views around communism and socialism. Those words would flow right behind what you described as why we can't do it. We're not that way. I would say that
Right.
is a pretty strong thread in my experience, whether I believe it or not is immaterial. It's just that we could design it a different way, much more like the Affordable Care Act was developed, in truth, as a market-based approach. But as you have to have just about everybody in there, then you have to think about it intelligently to construct the rest of the system so it reinforces what the aims are. And again, the aim needs to be about promoting our health and serving our needs as patients and people, not perpetuating the system for the government and the insurers or even the providers.
Yeah, and I think one of the I did an article several years ago now where I kind of did my own if I could rebuild the healthcare system, what I would do. And I talked about how I'd experienced a couple different systems. I'd had Medicaid in Colorado, I'd had Medicaid in Washington, and also lived through our transition from the state run to hiring a health insurance companies because we moved from Washington Apple Health to then
Right?
you have to pick an insurance company. Um, and then I've also paid for my own cash healthcare. I've also paid for health insurance, which is what I do now because I'm an entrepreneur, so I pay myself. Um, and I called a health insurance broker and he helped me out. It was great. Um, and so one of the things I had in Colorado that I thought was really cool and could offset some of the costs, and I kind of want to get your feedback on this, is for prescriptions, there was a $1 to $5 fee system. If it was old and cheap and generic, $1. If it was new and expensive and fancy, $5. And everything else in between that sort of thing. And I thought, what if we had an income-based fee structure? Whereas like if you're poor, like you make under 40,000, you pay nothing. And then another tier, small amount, kind of capping out maybe $150 or whatever have you. Based on your income. And if you get unemployed, you can file a form and get into another tier and all this sort of thing. And I thought that would because one of the problems is costs. Healthcare is expensive. And even if you take all the money from Medicaid, all the money from Medicare, there's a funding gap there that the Bernie
Yes.
Sanders campaign never really wanted to admit was there, but was there. And a payroll tax would fill part of it, but I also feel like if you took all that money, put that together, had a small payroll tax, and then also had a fee thing, it would feel like insurance. I even told my mom, I said, we should call this Patriot Care or Make America Healthcare Again or something American and patriotic, put an eagle on the front of it, sort of thing, to convince people in red states it's a good idea.
That's right.
you know, but I thought like that it would feel like health insurance you're used to because 188 million Americans have health insurance, usually through their employer. That percentage is going down, but usually through their employer. And it's like if you made it feel and sound like insurance, then maybe people would accept it. What do you think about that?
Yeah, well, I think you're on the right track, especially with why you would do it. It's to really placate certain points of view about why this might be a good thing to think about for everybody. And the
Right.
notion of some sliding scale, more equitable way where everybody has skin in the game is how it's frequently described,
Yes. And you
would
could contract the
placate a
health
lot of
insurance companies
people.
to deliver it. So they're still there. We're not going to get
Yes.
rid of them, which will keep them happy because they will not tolerate getting put out of business. So we'll hire them to administer it for us, sort of thing, and go from there.
Yes. Yes. But meanwhile, just as long as we understand there are fallacies to it. One is just
Right.
that there's this notion that somehow by doing that, it's really going to affect the demand for care and how much people use it because if people have skin in the game, it really affects their decisions about how they buy healthcare.
Right.
Well, that's not my experience. Most studies don't show that's the case either, that it's kind of an illusion. Most men don't want to get healthcare unless their wives force them to go get it, right?
So
So
that's
whatever
half
the
the
copay is,
population we
doesn't
don't have to
matter.
worry about. We'll talk to the
Exactly.
women now. We'll just talk to the
Exactly.
ladies now. Yes.
Yeah, so it's as long as we understand there's kind of an illusion to this thing. It's just about making it appear to be a more equitable system from whatever our social points of view are. The other harder part about your example is it's using pharmaceuticals. It's not a question about dollar and or $5 payments. It's about drugs that cost $1,000, $10,000, $30,000 for some of these cancer drugs, and
Right.
not on a yearly basis, but a monthly basis.
Or per
So we're
treatment
talking about,
sometimes. Yeah.
yes, and we're talking about a whole different universe and a whole universe behind that of why it is we're paying so much more in the United States for those than any other nation in the world. We're essentially paying for R&D for the globe. Maybe
Right.
that's the right thing, maybe it's the wrong thing, but the way it's being financed from a equitable standpoint is kind of crazy and makes no sense at all. So somehow
Yeah.
intervening in the pharmaceutical world is something that comes up a lot in DC. I think might be one of the things that even happens under the new administration. We'll see, because it's just so
Yeah.
egregious in how it's structured right now.
Well, I mean, that's why, I think having, part of the payroll tax and then also having a fee per drug, per visit, per specialist, all this type of thing, that then kind of gives you a pull to play with. But I agree with you. We do, and I realize this. I'm so glad that you mentioned that we pay for R&D for the globe because I had figured that out several years ago and no one believed me. And I said, no. I said, the reason why drugs are cheap in France is because they do bulk discounts they negotiate contractually. And in
Yes.
order to pay for that loss, the health insurance companies charge out the ass for the place they don't have to do that. Why do you think they fought Medicare negotiating drug prices so hard? Because they've been bilking us, the federal government, for decades to offset these huge R&D costs. And what's even kind of more stupid is the initial research isn't paid by them either. It's usually paid by universities through government grants for research. They're basically trying to offset the cost of the clinical trials, which is no small expense and take 5 to 8 years to bring a new drug to market, minimum sort of thing. They're basically offsetting that cost onto us, and literally no one else on the planet is paying it. And that's now that one I will say I don't have a clever idea on how to fix that. That
Yeah.
cost has to go somewhere. And Lord knows Pfizer and company are probably not even really able to shoulder all the costs of bringing new drugs to market. And I don't exactly know what you do about that.
Yeah. Well, one thing is if we stop being the deep pocket as easy as we have been for decades, they will find solutions to that problem, I think, and
Get a
that's
little bit
probably
more
how it'll
efficient about
work.
the whole thing. Yes,
But
no, that's true.
but it
Yeah.
also brings to mind this is kind of the crazy thing about healthcare when you start to think about fixing it, unlike just about anything else. If you look at the tremendous advances technologically and our ability to intervene in this weird thing called life and death,
Right.
it is many of these pharmaceutical discoveries that are changing our time spans in terms of our life. Um,
True.
I've seen cancers that were untreatable when I was much younger, now being things that if you get them, oh, we can take care of that. We're
Yeah.
seeing things like some of these weight loss drugs in Ozempic in terms of intervening in diabetes, just showing tremendous potential, not just for diabetes, but strokes, heart related care, Alzheimer's, and the list goes on and on. So, and so this whole question about how to really fund this discovery, which is the incredible part of healthcare, is something we not only have to manage, but we have to make sure we don't shoot ourselves in the foot while we're trying to find a solution to the cost problem, because it might be the
Yeah.
future for a lot of our destinies.
No, no, I mean that's very I mean when I was young, my grandma had cancer right around the first time, right around the time I was born. I think I was 3 or 4. And I mean this is the late 80s, early 90s, because I'm old. And it was a quite serious thing, and the interventions were quite, tremendous. The second time she had cancer, radiation had arrived by that time. It wasn't as pinpointed and refined as it is now, but it was, I mean, at the time that was a great new innovation because it wasn't chemo and it wasn't just surgery and all this type of thing. And there's been all of these things, and now, you know it's gone from the this is really bad, could be a death sentence, hope some of this stuff works, sort of thing, to the, oh, breast cancer, that's really, really terrible. So, yeah, so we're gonna do some treatments, maybe some reconstruction, mastectomy. And I mean, your chances of living in my lifetime, we've gone from the, this is not great and you might go, to the, oh, yeah, your chances are pretty good by and large.
Yeah.
We'll do some stuff, sort of thing. And some of the rare ones, even my uncle, he had leukemia several years ago. He went to the hospital in Cheyenne, Wyoming one night and didn't leave for almost a year and a half. And he was saved by an experimental drug from Novartis. They got him
Hmm.
into a clinical trial, and now he's, flying drones in the Wyoming wilderness and all this sort of thing. And not but a generation ago, that would have been a death sentence. I mean, I'd be talking about my uncle in the grave in Wyoming, not flying drones in the Wyoming wilderness sort of thing. And people are regularly living into their 80s and 90s and doing well.
Right.
Half of them sit in Congress, sort of thing. So, I mean, I mean, people, I mean, even just the definition of old has changed.
Yes.
Like, even like my mom turned 69 this year, and she's older than when her mother passed, and my mom is less old than her mother was. My Nana is 83 and just stopped driving a couple years ago and is still actively doing stuff, actively engaged, all this type of thing. That was not true
Right.
that long ago.
That's
But a lot
correct.
of it has to do with, all the wonderful things that we've done. How Nana had her other knee done 2 years ago, and it was amazing how fast and different that process was. Now, fuck, people go in and get two knees done, and they're playing golf in 2 months, sort of thing.
Yeah.
And it's quite tremendous what has happened. I just think I think for me the tragedy of American healthcare, and I kind of want to get your feedback on this. The tragedy is, I mean, I'm very lucky. My family has a lot of wealth and privilege to be able to afford to do that and live those great lives and all that sort of thing. I think the problem is a lot of people fall through the cracks, and I see it among my friends, and I'm late 30s. I'm 37 in 3 months. Um, with, chronic nagging conditions, terrible stuff. And, if they have healthcare, it's not that good. It costs too much, or they can't afford it at all, or whatever have you. And the small problems that a bit of preventative or some medication would solve end up becoming terrible problems in 5 years because of no healthcare, and it's destroying lives and careers and all this type of thing. Um, I guess when it comes to the preventative side of things, how do we bring that into American healthcare? Because that's kind of the dirty secret in the rest of the world. They save money by stopping problems before they start. Like, that's a big part of what they do.
Right. Well, their orientation is less sick care and more just trying to spend what they have in their more integrated systems.
Right.
So again, it's all these consequences of not being able to systemic point of view about how things work, and the calcification around trying to create change, I think is really
Mm.
the source of the true problem. It's not that the things just, I think most people would agree with what you described. In fact, some of my work used to be proving that most people agreed on these statements about the importance of prevention and thinking about it differently. There's always the how do you get from here to there? And it continues to be the case. Let me bring it out a different way. It's one of the challenges of trying to write the books that I write,
Yeah.
because in writing medical thrillers, you need heroes and you need villains, and
Hmm.
you don't get confused about who's who, and when you start to solve the tale. Well, in
Yeah.
healthcare, a lot of what has happened in our system, it is just developed around medical discoveries going back into the early 1900s, when we started to discover things like anesthesia and the germ
Yeah.
theory disease. This is really what accelerated the creation of the American healthcare system and most global health systems. And they just sort of organized around these discoveries and the possibilities that were there and getting them out to people. And that was what started to create how healthcare got structured. And we've never been able to put the genie back in the bottle in terms of stepping back and saying, how would you design it and do it right? So you asked about prevention. Well, I mean, it's just so obvious that we spend so much more as a country and get such worse outcomes because we are so poor at prevention. Even in how we use the language to describe our healthcare system, it is a healthcare system. I once was the head of an organization, and still am, called the Washington Health Foundation. People
Mm.
ask me, how come you're not the Washington Health Care Foundation? I said, because we aspire for health, not for health care, right?
Yeah.
And sort of
Right.
getting at again this tension and what we really is the right thing to do. Again, I would go back to my set of solutions, which get into the practicality of trying to organize this around from a person point of view, which would pretty quickly say, if you want to just use one example, that, well, gee, if this person has diabetes, wouldn't it be way cheaper to make sure they get their insulin than somehow wait until they need to have their foot amputated, have a coronary, have stroke,
Yeah.
eye disease, the problems go on. And there's just example after example of that type of thinking and trying to incorporate. preventive thinking into our current system just runs into a loggerhead with the way the system's structured. Right now, we're seeing a pushback. Just this week, there is a Supreme Court agreeing to hear a case about the prevention elements of the Affordable Care Act that
Yeah.
require these prevention policies in the Affordable Care Act insurance policies. If that somehow goes the wrong direction, it could be a huge setback for the prevention movement in this country, which has been struggling to even reach the what were the dreams of including those provisions in the Affordable Care Act back in when it passed. Again, this is the problem we have is how do you get this right thinking that most people agree with? Again, this is not Democratic or Republican thinking, although whenever these issues come up, they get put into their boxes for political purposes. But how do we practically reach a consensus that is out there for designing this the right way that will really help the American people in going forward?
Yes, absolutely. And that is a quite I think a quite meaty problem that I think definitely deserves addressing. I think that's really what, in my experience of healthcare in other countries, is what really kind of separates it all. And I think what kind of horrifies people about our system, people, they go to the, they have a problem, they think they have a thing, they go to the doctor, try to, get care, all this sort of thing. Um, and people are always kind of like, well, I was like, I don't want to be on a waiting list. I don't want to have a community decide my fate. It's like, I had this argument with my mom. I said, Mom, this already is a thing. Your health insurance company's doing it. It's called
Right.
pre-authorizations. It's when
Yes.
they deny claims. And I told mom, I said, literally, Mom, which would you rather have? Would you rather have to be beholden to a private profit-seeking company or a government system who we can modify through our vote and our politicians? A company, we can't do anything to them. They do not care. So their job is to make money and damn little else. I said, whereas under a different system, we could have a health service, and if it's not doing what we want it to do, we can call up our Congress critters at the state and federal level, and we can get something moving. And it's like
Right.
they closed a hospital near where my parents lived. And my mom's like, oh, it's really sad we have the hospital so far. I said, you know what, Mom? If we were under a national system, we could go down to the state capitol in Denver. My parents live in Colorado. You could cruise on down to Denver and you could talk to your state rep and your state senator and complain that your hospital has been closed and we should reopen it, sort of thing. But it's a private company, so you get nothing, Mom. Sorry, like you get nothing on that one, sort of thing. And it just seems like it's such a gap to be kind of like, it doesn't have to be this way. We could
Right.
do something different. We could have it a different way. So I definitely see the challenge in the one boomer voter I talk to all the time.
Yes.
It's
Yes.
it's
There
always
you
it's
go.
definitely a challenge for
Right.
sure.
And,
Yeah.
and meanwhile, what you're describing is actually getting a bit worse, I think, unbeknownst to a lot of people, which is the notion that somehow we could battle these local health systems in your communities is
Mm.
starting to fade away. For almost my entire life, healthcare financing has been at a larger scale, the federal government or state government level, but most of the delivery of care has been quite local, mostly
Right.
community-based hospitals, whether that's a geographic community or a church hospital related hospital or cause related hospital, union hospitals, things like that. Well, that's starting to change pretty rapidly and really started to accelerate during COVID when we were so preoccupied with that. More and more, these organizations are growing and integrating horizontally, geographically, and vertically, even including insurance elements. So more and more the outfits you are battling are no longer the ones that you actually have much say about. They might not be anywhere near where you are. I'm in Arizona right now. If something
Mhm.
happens to whatever's going on with me, most likely if I wanted to complain to the organizations that I deal with about it, they'll be in Minneapolis or Boston or
Yeah.
somewhere far away. And more, this problem is in terms of scale of these organizations around healthcare growing is becoming something that's really problematic in terms of how do you create systems that can actually intervene.
No, I mean, insurance companies are increasingly responsible for delivering care by owning large medical practices and hospitals and all this type of thing. One of the things I counted myself lucky for living in Seattle, we had a University of Washington owns a lot. Swedish is the other big system. There's a third one. Oh, it's I used to have it in West Seattle. It's on the tip of my tongue. Can't think of it right now. There's a third one.
I lived there for a long time. There's Harborview, which is where people went when they had nothing else.
Yes, I lived 4 blocks from Harborview, actually. It's actually now owned by UW, but I lived
That's right.
literally on Yesler at 6th was
Uh,
where I lived. And so literally if you go around the corner up the hill, that's where you're at. And so yeah, it's that yeah, there was there was a great another system. I used to go to their clinic in West Hill. I can't think of it right now. Um and it's Catholic of some description. And
oh, Providence is what you're talking about.
yes, I think so. And
They've
so
merged with Swedish mostly to sort of be an example of my point.
yeah, yeah, exactly. Yeah, that's kind of what I was getting to was kind of that consolidation. Like even Harborview got swallowed up by UW. Sort of. That's now part. It was able
Sort
to do
of.
a whole big campaign. Yeah, it's kind of sort of, but there was a lot of banners, big campaign, sort of
Yes,
thing.
exactly.
And
Exactly.
so
New logo.
yeah, yes, exactly. And they're remodeling. They're building a new wing. They're tearing part of one building down. They were starting that on Yesler right as I was
Yeah.
moving, and I was so glad
Yeah.
to be leaving when that happened because I'm like, I
Yeah.
don't want to live next to that for 2 years. Like
And
so,
all of them are described as this will be better for you. Whenever
yes.
it's done happening, you go, how is that better for me?
Well, I mean, and this is the problem with all this consolidation is and all this integration, as even true with mergers of retail and restaurant. A lot of promises get made, very few of them ever get
Yes.
delivered. And that I think is a big problem. And people have fewer choices.
Yes. Sort of like the
I mean, you're
airlines.
down. I mean, in Seattle, if you're not if you're not a UW patient, your only other choice is Swedish. I had this problem I had when I was working with I was diagnosed with autism and ADHD 4 years ago. 4 years ago next week, actually, and we were looking for a pulmonologist. And I was literally my choices were I had 2 phone numbers. There was the pulmonology at UW, and there was the pulmonology at Swedish, and that
Right.
was it, sort of thing. Um, and that was it was kind of like I was like, I live in a major American city, and that's my options. Okay. This, I mean, and if you don't live in a big city, you may only have one game in town, you know. And that's it's especially like in the South, you have the Baptist health system and all this thing. You may like when I lived in North Florida, that was it. You had Baptist Health, and that was all, sort of thing. And there's
Yeah.
a lot of this country that doesn't live in a big city that can support multiple systems and sort of thing. And so you end up with only one thing in town, and if they can't see you or won't see you or have a waiting list out forever, you're stuck, you know.
If you have that, a lot of the rural hospitals and systems are under threat. In fact, it's the topic of my fourth book that I'm writing now.
Oh, really? Our detective goes to rural America?
Yes, Frontier Health, exactly.
Yes, there's a popular doctor who does skits named Dr. Glaucomflecken, and he has some hilarious skits about rural medicine, including the farmer pain scale. If I'm here, you should be worried, sort of thing. And yes, his skits on rural healthcare are absolutely hilarious. So it's all fascinating. Before this has all been a great conversation and absolutely fascinating. But before we go, I want to talk a little bit about process. How do you get in the writing mood?
I've learned is I had to create a new set of habits around how I used to be a healthcare executive, just a new set of ones, and it's harder because there's nobody watching. At
True.
some point, I'd have employees or colleagues or bosses who would be wondering what I'm doing with my time. Right now,
Right.
it's my dogs and my wife. If she cared enough, as long as I'm out of the house, she's happy. So I have an office. I have a couple of different locations where I live. One in Washington State still, and one in Arizona. So in Arizona, I have a casita. So every morning I trudge out to the casita, and no matter how I feel, it's like, okay, I'm going to be here for a few hours. It's time to write something. And so it's
Yes.
just, again, it's just habit. I don't have the commute I used to have, but you got to
Yeah.
get in the habit where you're doing this regularly, or it is just a hobby instead of something you're really committed to doing.
No, no, I totally understand. I have been doing this full time for 6 years now. Again, I was, and then I quit and went off and got jobs and paid off credit cards and felt better about my life. And then I got talked into doing this business again. And one of the things I realized is I need to start blocking time in the schedule because if I don't, and especially with the number of podcasts I'm doing, I'm going to shoot seven, you're number seven. I'm gonna shoot another, there's one right after you. I'm gonna shoot 8 these weeks. I've got to start blocking out
Wow.
the time to make all of my podcast guys schedule schedule around my writing time, because otherwise it's very easy to get busy doing a bunch of these and then never get to the actual writing time. So I totally feel about building that habit and, making that time to get that done and everything. So it's it's definitely I definitely understand that. Or do you kind of let the words come out as they come, or do you plan an outline? I say as a big outliner person.
Now, I'm not a big outliner person. I have an idea of my story typically to
Mm,
start, and I start to just create ideas. When I sit down, I never know what I'm going to write about, almost never, unless it occurred to me while I was sleeping that night in a dream, which
yeah,
sometimes does happen. But I'll basically sit down and sort of like, well, what do I want to write about? And with the new software that's out there for writing books, I can just write a chapter and move it around wherever I want to pretty easily. And what I do is typically that for a few months. And then at some point, I'll sit down and say, what do I got? And then I'll
yeah.
realize that I've got all these really thorny problems, some really good chapters, some really bad ones. But mostly I tend to find is what I have is a huge problem, and it's creating the structure of the novel and no answer.
Mhm.
And then I panic and I go like, well, I have to solve this. And
Yeah.
then I just sort of go into a couple week period where I'm just always wandering around going like, how do I get him out of this? I got him so deep into it. And I find just magically one day I'll wake up and go, oh, I got it. That's sort of my
That
process.
Yeah. No, no, no. I totally go, yes, all the stages, all that sort of thing. That's absolutely fascinating, and definitely looking forward to that fourth book. So, well, I'm gonna get you moving on because I have another recording right after
Okay.
you. And so I need 2 minutes to myself before they show up. So, why don't you let this, but this has been fascinating, and thank you so much for coming by and talking about this. This is obviously such a hot topic as we head into the Trump administration and with recent events having evented. And it's very exciting. Why don't you tell us where we can find you online and where to buy your books?
So the best way to connect with me is I have a new author website, gregvigdor.com. Gregvigdor.com, really just the way it sounds. And I also, through that, you can sign up for a newsletter. I am writing commentary pieces around the new Trump administration policies, whatever sort of strikes me on a month-to-month basis, as well as my books. The third book, called Death Panels, is already out in paperback. It'll be released this coming Tuesday, January 21st, in ebook form. And you can go on to Amazon to buy the books there, or you can get to Amazon through my author website, which again is gregvigdor.com.
Excellent. Well, thank you so much for coming on the Cameron Journal podcast.
Enjoyed it.
That's all for this episode of the Cameron Journal podcast. Thank you so much for listening. Visit us online at CameronJournal.com. We're on Facebook, Twitter, and Instagram, and I love to talk to my followers and listeners, so please feel free to get us on social media at Cameron Cowan on Twitter, and we'll see you next time on the Cameron Journal podcast.